Um, Assalamu alaikum, everybody. So we can start our free paper session for today. So myself and Dr. Raza will be chairing the session. So can I invite the first speaker for their talk? It's going to be Amina Nawab talking about complexity of anastomotic leak after colorectal surgery.
Assalamu alaikum, everyone. My name is Dr. Amina Nawab. I am surgical resident in Surgical Oncology Department, Peshawar. And today I'm going to present the topic of presentation of mine is like unveiling complexities of anastomotic leak after colorectal surgeries in the patients who are diagnosed case of colorectal cancer. So first of all, we need to define the anastomotic leak. Basically, anastomotic leak is like after we are doing surgery, we do the resection of the tumor, and then we bring out the two ends of the balls, either like it's a colon or rectum or colon to rectum, and we are performing the anastomosis. So after surgery, when there is leak, so basically, we can define anastomotic leak is the complication of surgical anastomosis where there is a leak at the site of anastomosis after surgery into the surrounding organs. There are some causes of anastomotic leak. Some are the patient related and some are procedure related, and the others are disease related. And patient related, they are the age, BMI, for example, gender, and some morbidities. And procedure related, it's like type of procedures and type of anastomosis and surgical complications. And disease related, it's like a certain disease like weaken the immune system of the patients, like inflammatory bowel disease or other immune system. And the risk factors, there are two types of risk factors: modified risk factors and unmodified risk factors. Those risk factors which can be modified, like nutritional status of the patients, BMI of the patients, and some other factors which can be improved before the surgery. And some are the non-modified risk factors, like, for example, gender and age, and other morbidities which cannot be modified. So they are considered like non-modified risk factors. My aim and objective of this study is to analyze the anastomotic leak in a patients with diagnosed case of colorectal cancer, and those patients who underwent colorectal surgeries and performed anastomosis. My study is a retrospective study of 288 patients, and the approval taken from the IRB, and the data was collected from the hospital information system, and regression in COGS, logistic and COGS regression analysis are taken to analyze the incident and risk factor of anastomosis, and the p-value taken is significance less than 0.05. And all those patients with the diagnosed case of colorectal cancer, they done the colorectal surgeries, and they performed anastomosis are considered in inclusion criteria, also with complete data. And other patients with the patient who did not done any colorectal surgeries without anastomosis, and they are not colorectal cancer, and also with incomplete data. So total number of patients, they were like 288. Out of them, they are 213 male and 275 female. And out of 288, 284 were elective, 4 were opens, and 9 emergency, and 179 were laparoscopy. So logistic regressions analysis and COGS regression analysis performed on the given sample data. So in my logistic regression analysis, there are certain variables which are taken as a predictor on left side, and the blue lines, they are showing the OR ratio. So any of the variables whom they are crossing beyond the level of the one they are taken is a positive, and they have values more than one, so they can increase the incidence of anastomosis after surgery. And those who have values or odd ratio less than one, they are taken as a negative. And on the other sides, there are some positive and negative correlations with anastomosis. So after my analysis, I found out positive correlations with all those variables whom have a less than OR value. They are like the stages, TNM stages, in operative time, the blood loss and hospital stay, and emergency surgery versus elective, and open surgery versus laparoscopy, BMI, age of the patients. They have a positive correlation with anastomosis. So they have a value more than one. And the other with the negative correlations and have OR less than one, they are taken as a negative correlations, and they have a protective effects in anastomosis. And when I perform the Cox regression analysis, so there are the certain variables and have again some positive Cox regression analysis correlations, and like age, male versus female, diabetes, open surgery versus elective, emergency versus open surgery versus laparoscopy, emergency surgery versus elective, and BMI or in the rectal cancer versus colon. And other variables like laparoscopy, elective, and mechanical anastomosis, they have a negative correlations and they have some protective effects. So the result were like the age, male genders, and high BMI, low preoperative serum albumins, and blood loss less than blood loss like per every 10 ml of the blood loss have significant effects and the risk for the anastomosis. Colorectal cancer have more chances than colon cancer. Patient with diabetes, hypertension, and high TNM stages, high CA value, and emergency versus elective, they have a significant effects on anastomosis, and the p value was like significance. And I did a study on some meta-analysis. They discussed multiple variables in patients and of large sample data, and they discussed that the patients with low serum albumins and male gender versus female, again, elective surgery versus emergency and laparoscopy versus open, they can increase the chances of anastomotic leaks. And my other meta-analysis, they have the same result of discussions, and they discussed large sample data, and they discussed again the age and the low serum albumins and the rectal cancer versus colon cancer, and the stage of tumors. They have significant positive effects on anastomotic leaks. So my conclusion is all those patients who have with the increase of age, male gender versus female, with morbidities and higher TNM stages, high CA level, preoperative low serum albumins, and weak nutritional status, high BMI, and blood loss during a surgery, and they have some effects on patients, so they can increase the chances of anastomosis. And some of the variables like if we can perform laparoscopy versus open in elective surgery versus emergency, and the type of anastomosis like mechanical versus some other type of anastomosis, they have a positive, they have protective effects on anastomotic leaks. So the limitation of my study, like it's a retrospective study in small sample size, incomplete predictors data, uncontrolled confounding factors, and we need a further study and further research on this topic basically, so we can provide and confirm the the exact relationship of all these variables which can cause the anastomosis in the patients with those surgeries. So these are the reference. Thank you.
Why do you think laparoscopic surgery reduces the anastomosis?
Sir, laparoscopic surgery versus open, they have like there is a difference in open surgery. They expose the patient, and like there are the more exposures to the organs. I think that could be the cause. And in laparoscopic surgery, there is a less loss of blood as compared to open surgery. And the risk of infections, obviously, it's less chances of risk of infection, surgical site infections in laparoscopic surgery versus an open.
Any more questions, comments? Okay, thank you very much. We'll move on to the next paper. So the next paper is going to be presented by Khayal Azam Khalil on role of lymphadenectomy in management of early stage endometrial cancer.
Assalamualaikum. My name is Khayal Azam Khalil. I'm working as fellow gynecology oncology at Shaukat Khanum Hospital in Lahore. I will be talking about the role of lymphadenectomy in the management of early stage endometrial cancer. I don't have any conflicts of interest to declare. Endometrial cancer is one of the commonly occurring gynecological cancers. The need and type of adjuvant therapy in early stage endometrial cancer is reliant on the histopathological spread of the disease, which is usually established post surgery, as surgery is important for staging the disease. Lately, sentinel lymph node mapping is becoming the standard of care to guide pelvic lymph node dissection, as was also discussed earlier in the gynecology oncology session of this symposium. My objective was to determine the role of pelvic lymphadenectomy by assessing nodal positivity on progression-free and overall survival in early stage endometrial cancer. This was a retrospective cross-sectional study. Data was collected from the hospital information system from January 2019 to December 2023, and it was conducted at the Department of Surgical Oncology at Shaukat Khanum Hospital, Lahore. So all patients with early stage endometrial cancer, which are stage 1 and stage 2 disease, were included that underwent pelvic lymph node dissection. Nodal positive disease was noted on histopathology. Then we moved on to look at details of adjuvant treatment and the incidence of first recurrence. 89 women were found to fulfill the inclusion criteria, which as I mentioned, was early stage endometrial cancer, stage 1-2 disease, who underwent pelvic lymphadenectomy during surgery from year 2019 till 2023. Exclusion criteria was women who did not undergo pelvic lymphadenectomy or did not have any histopathological evidence of lymph node tissue on this submitted specimen. Women with advanced stage endometrial cancer were excluded. Women with ECOG performance status more than 3 at presentation, which means poor performance at presentation, were also excluded. BMI more than 40, so morbidly obese women were also excluded. Those who were lost to follow-up had more than one primary cancer, as it had impact on oncological outcomes, were excluded. Patients with incomplete adjuvant therapy data and patients who contracted COVID-19 during the treatment were also excluded, as my data was from the pandemic era as well. Statistical analysis was done using the SPSS software version 25. Descriptive statistics were used to calculate mean, median, and frequencies, and survival curves were made using the Kaplan-Meier method. These are the patient characteristics. The mean age was 54.78 and mean BMI was 32.2. This is a comparison of all the various variables. There were 65.2% laparoscopic surgeries performed. 18% patients received adjuvant chemotherapy, 51.7% received adjuvant radiation. We had a total of 6.7% patients who had nodal positive disease, and it is important to note that we are talking about early stage endometrial cancer. So these patients presented as having early stage disease, but were found to have metastatic disease in 6.7% patients. The most common histology was endometrioid adenocarcinoma, which is expected. As these were early stage cancers, the superficial disease, which is less than 50% myometrium, invasion was the most common in our cohort. These are the survival curves. The progression-free and overall survival was good because these were early stage disease patients. The most prominent results were only 2 patients underwent para-aortic lymphadenectomy in addition to the usual pelvic lymph node dissection. Um, 17 patients had lymphadenopathy on scans, so preoperative scans. 6 patients were found to have nodal positive disease, out of which only 3 had lymphadenopathy on scans. 26 patients had cytological evaluation of peritoneal fluid. This was done on the discretion of the operating surgeon. So no particular preoperative indicator was found for patients who had cytological evaluation, and 4 of these patients had positive malignant cells. Among the patients who had lymph node positive disease, only 1 patient went on to have a recurrence despite adjuvant therapy. So we concluded that patients who underwent pelvic lymphadenectomy and were subsequently found to have nodal disease went on to receive adequate adjuvant therapy. However, there was no specific preoperative indicator to prompt the decision of pelvic lymphadenectomy. These are a few studies that have been conducted previously. The first one shows a selective anatomical based lymph node sampling that can replace site-specific sentinel lymph node site-specific lymphadenectomy in a failed sentinel lymph node mapping. So I would like to mention that sentinel lymph node mapping is currently not practiced at our institution. They've concluded that if we perform bilateral pelvic lymph node dissection in the obturator fossa, the internal iliac region, and the parauterine lymphovascular tissue, has similar oncological outcomes as a complete pelvic lymph node dissection. Another study looked at the prevalence and size of pelvic sentinel lymph node metastasis in endometrial cancer. They found that 12.7% women who were preoperatively assumed to be low-risk endometrial cancer had metastatic sentinel lymph nodes. The proportion of the small volume of sentinel lymph node metastases were related to the endometrial cancer histological profile. So endometrial cancer molecular profiling, which has recently been included in the endometrial cancer staging, is also not being done at Shaukat Khanum at the moment. And the importance of this was also emphasized in one of the talks at the gynecological oncology sessions this morning. Detection of sentinel lymph nodes should be performed in all women in endometrial cancer. This was their conclusion. So omitting pelvic lymphadenectomy completely is not an option. Lymphadenectomy for high-grade endometrial cancer, does it impact lymph node recurrence? So this study concluded that positive lymph nodes at surgical staging predict nodal recurrence. Recurrence-free survival is longer with positive lymph nodes when more extensive lymph node dissection is performed. So surgical debulking may have a role in the oncological outcomes of endometrial cancer. For future consideration, we can incorporate sentinel lymph node technique at our institution, ideally using the ICG dye, which is considered more accurate. But other alternatives, cheaper alternatives like methylene blue dye, which is already available, can be considered. And as mentioned this morning, it can improve the lymph node mapping by at least 3 times compared to doing it without any using any dye. Thank you.
Any questions or comments from the floor?
I really enjoyed that. Thank you. I presume your radiological staging was simply cross-sectional CT scan, was it?
We do a pelvic MRI as well.
Does PET CT scanning have any role to play in the assessment of nodal disease?
We do use PET CT for to look at nodal recurrence. PET CT is usually not the first line of modality, especially preoperatively. We don't look at lymph nodes with PET CT preoperatively in endometrial cancers.
But given that your staging is perhaps not very good at the moment of the lymph node disease, do you think PET CTs could be used in the initial staging?
Well, from what I've heard, that PET CT could still miss about 30% of lymph node metastasis, and histopathology still remains gold standard. So I think surgical staging is still superior to PET CT.
Just one more question from my side. Anything which has come out from this data that has made you change your local practice?
Yes, I've presented this topic a few times locally in our unit, and we are thinking about incorporating a methylene blue dye to improve our accuracy of picking up lymph nodes during surgery.
Thank you very much. Any further comments? Thanks a lot.
Thank you, sir.
Now I invite the next speaker, which is Khalil Farooq, who's going to talk about outcome, complications, and survival of extremity sarcoma treated with megaprosthesis.
Assalamu alaikum. My name is Dr. Khalil Farooq, and I am working as a fellow orthopedic oncology at Shaukat Khanum, Lahore. So my topic of presentation is outcome, complication, and survival of extremity sarcomas treated with megaprosthesis, comprehensive analysis of 115 cases in a cancer-dedicated hospital. So these are the megaprosthesis, which we were talking about. So in the picture A, you can see that the pelvic resection is done and a lumic cup is applied along with the proximal femoral replacement. In picture B, you can appreciate distal femur replacement. In picture C, you can appreciate proximal tibia replacement. And in picture D and E, you can appreciate proximal humerus replacement. So I have no financial disclosures, and the article is now published at Curious. The introduction in the late 20th century, limb salvage surgery emerged as a game changer for treating musculoskeletal tumors, evolving with advanced techniques to offer both survival and functional outcomes. Despite hurdles such as delayed presentation, poor biopsy scar, massive tumor size, it is crucial to understand and address complications. So the objective of the study was to discuss key metrics such as overall survival, metastasis-free survival, recurrence-free survival, functional outcomes, and complication in patients treated with megaprosthesis for extremity sarcomas. So this was a retrospective analysis of a patient with primary malignant bone carcinomas from January 2017 till December 2023, and patients were followed till June 2024. The patients of all group ages were included who are undergoing megaprosthesis for extremity sarcomas. Variables assessed included patient age, size, and anatomical location of the tumor, metastasis, histological subtype and stage, grade of tumor, resection margins, treatment provided, functional outcome, and complications. So patients with high-grade tumors, that is grade 2 and 3, were tend to receive neoadjuvant chemotherapy, and whereas sarcomas not sensitive to chemotherapy or radiotherapy were directly sent for primary control, that is surgery. So all patients were discussed in a hospital multidisciplinary team meeting before tumor staging. So for each patient, limb salvage surgery with thorough tumor resection, followed by precise placement of megaprosthesis were performed. The data was analyzed using SPSS version 27, 5 years metastasis-free survival, recurrence-free survival, and overall survival were analyzed using Kaplan-Meier method. So coming to the result, we have analyzed approximately a total of 115 patients, among which osteosarcoma was the most common finding in 68% of the patient, followed by Ewing sarcoma in 14% and chondrosarcoma in 12.2% of the patient. Majority of our patients were male, 64%. When age group is seen, then the majority of our patients were 12 to 18 years of age, that is comprising approximately 60.8% of the patients. When the south type tumor is concerned, distal femur was the most common site, followed by proximal tibia, proximal femur, and the proximal humerus. Only 2.6% had pelvic disease. So out of 115 patients, 20 patients, that is 17.4% patients were expired, 6 patients were lost to follow-up. The overall survival rate of approximately 78%, as seen in this Kaplan-Meier chart. 14 patients had local recurrence, and the 5-year recurrence-free survival rate was approximately 83.2%. And 27 patients, that is 23.5 patients, had distant mets, and 5-year metastasis-free survival was approximately 67.5%. So when we looked at the complication, total of 31 patients, that is 27% of our population, had a complication, with 11.3% patient having local soft tissue related complication, which included superficial skin necrosis, superficial infection. That is followed by 2.6% of the patient with prostatic joint infection, 1.7% with implant dislocation, and 0.9% of the patient with periprostatic fracture. So with big surgeries come big complications. So this is an example of a periprostatic fracture in which the patient presented to us with the fracture of this megaprosthesis. So we revised the patient, and this is the picture after the revision. So another case, when we did the pelvic resection, there is a loss of abductor constraint around the hip joint. So dislocations are common in these patients. So this is an example of the dislocation of the prosthesis, and open relocation was performed in this case. So metastasis, musculoskeletal tumors society score was also seen in this patient, and we seen that the excellent to good outcome was achieved in 72% of the upper limb megaprosthesis patient, while 60% of the lower limb patient had the excellent to good outcomes. We also see some secondary outcomes in which we compared the margin of resection and tumor necrosis with the overall survival, metastasis survival, and recurrence-free survival. And we found out that the tumor necrosis has a positive correlation with the overall survival. Metastasis-free survival has both positive correlation with the margin of resection and tumor necrosis, while recurrence-free survival has a positive correlation with the margin of resection. So this is the discussion in which we compared our study with 3 other studies, one in Italy, one in China, and one in France. And we see that we have a 7-year data, and we have 115 patients, which is far more than any of the above studies. And surprisingly, we have 78% survival rate, which is a very good survival. And we had only 27% of the patient with complication, which is comparable. And only the prostatic joint infection, we have reported only 2.6%. So in conclusion, we observed a good functional and survival outcome in patients treated with wide margin excision and of bone sarcomas and reconstruction with megaprosthesis. Thank you. Are there any questions? Thank you. Like this for this how long
functional in a patient.
Yes.
So is that then a consideration for choice of these operations?
So the life of these implants is usually 15 to 20 years. And after that, most of the patient will require revision surgery. So on an average, 20 years is the minimum time if the patient uses that well. We counsel the patient regarding the implant care, that what precaution they should follow to attain such long survival. Thank you. Yes.
Surgical outcomes.
No, in this study, we don't see any correlation. Basically, we categorize the patient according to the diagnosis. That is, those patients who had osteosarcoma or Ewing sarcoma and were grade 2 and 3, they received neoadjuvant chemotherapy, while the patient that are not sensitive, that is chondrosarcoma patient that are not sensitive to either chemotherapy or radiotherapy, they receive first on surgery.
Okay, any more comments? Okay, thank you very much.
Thank you.
Right, I'll invite the next speaker, who is Shazeb Asif, talking about multivisceral resection for locally advanced gastric cancer.
Assalamu alaikum, everyone. I'm Dr. Shahzeb Asif. I'm a surgical resident at Shaukat Khanum Hospital, Lahore. The study I'm going to present is outcomes of multivisceral resections for locally advanced gastric cancers. It is a single-center experience. I have no financial interest, arrangement, or affiliation that would constitute a conflict of interest. So according to Globocon 2022, gastric cancer ranks as the 5th globally and 9th in Pakistan in terms of incidence and mortality. As shown in this pie chart, stomach cancers constituted about 4.9% of the patient. Locally advanced gastric cancers, or LAGC, represents around 30 to 35% of gastrointestinal malignancies that have progressed significantly. So the goals for treatment, as some patients present with the locally advanced cancer at the stage T4B, perioperative chemotherapy has proven to be beneficial. The primary surgical goal is to achieve negative resection margins or R naught resections. To perform adequate lymphadenectomy or D2 lymphadenectomy has proven to be increased in prognosis of the patients. In cases of locally advanced disease, multivisceral resection is necessary, including pancreas, spleen, or colon. So what happens is when the gastric cancer becomes locally advanced, it infiltrates the surrounding structure as well. So as the study showed that resectioning of multiple organs sometimes become necessary to have a good survival. So the recent advancements in perioperative systemic chemotherapy have improved the outcomes of surgical resection. Despite these advances, the overall prognosis for locally advanced gastric cancer remains unfavorable. The confined data explaining such discrepancies is limited. So our primary objective was to determine overall survival and the disease-free survival of the patients. So the aim of the study was to assess the potential benefits of multivisceral resection, or MVR, for patients with locally advanced gastric cancers. Both short-term and long-term outcomes for patients were studied. Safety and the effectiveness of procedures was studied. The biological impact of confirmed tumor invasion into adjacent organs despite achieving resection or negative surgical margins. To assess the survival implications of a radical approach aimed at achieving tumor-free margins in locally advanced gastric cancers. So the methods that were used were conceptualization and study parameters were confirmed. The operational definition of the study was defined. The approval was taken from the Institutional Review Board from Shaukat Khanum Hospital. The patient selection were histologically confirmed gastric cancers, and which were resectable and locally advanced. So data collection was done through hospital information system, and classification and data analysis was done through SPSS 20. So the data was collected from January 2011 to December 2020 retrospectively. A total of 258 patients underwent gastrectomy for potentially resectable gastric cancers. I repeat, there was no emergency surgeries, all were electives. 27 patients required MVR during surgery. Total gastrectomy was done in 74.1% of the patient. Subtotal gastrectomy was done in 25.9% of the patients. T4 disease was shown in the 40% of the cases. So the tumor organs that were resected with the gastric cancers were colon was 44.4%, pancreas 20.8%, and spleen was resected in 14.8% of the cases. Less commonly, resection of small bowel and liver was also performed. A complete resection or R naught resection was achieved in 81.5% of the patients. R1 was done in 14.8%, and R2 was performed, resection was performed in 3.7% of the patients. So 5 patients required reoperation during the same admission. Perioperative 30-day mortality was 0%. The median length of postoperative hospital stay was 11 days. The complications that were noted were in 10 patients, which constitute around 37% of the total population. The complications were further categorized as wound infection, 14.8%. Chest infection was also 14.8%. Anastomotic leak and duodenal stump blowout was 3.7% of the patient. So mean lymph node yield was 19, ranging from 11 to 46. Mean metastatic lymph node yield was 5.1, ranging from 0 to 25. So lymph node involvement was noted in 70.32% of the patients. The distribution were N0 in 29.68% of the patients, N1 and N2 in 22.2% of the patient, and N3 was noted in 25.92% of the patients. The survival function, which was the primary objective, was following discharge patients were monitored at oncological clinics at the interval of 10 days, 3 months, and 6 months. The mean follow-up period was 16 months, ranging from 5 to 72 months. These Kaplan-Meier curves were shown that the overall survival of 3-year survival was 73.1%, 5-year overall survival was 24.5%. And in the recurrence-free or disease-free survival was 3-year survival was 31.4% of the patients, and 5-year disease-free survival was 23.5% of the patients. The median overall survival was 15 months, ranging from 7 to 72 months. The median disease-free survival was 9 months. Recurrence was observed in 17 patients. So this chart compares our study with the Shizas D et al., which is a systematic analysis. According to this, the 5-year overall survival was 30.21%, while our 23.5%, and according to Zhang et al., their survival was 39.1%. So we concluded that multivisceral resection for locally advanced gastric cancer presents significant challenges but offers potential for improved disease control. Our research highlights the safety and short-term, long-term survival benefits of multivisceral resection in locally advanced gastric cancer. But the median overall survival of 15 months and disease-free survival of 9 months highlights the need for continuing revival of surgical adjuvant therapies to enhance long-term outcomes for patients with LAGC. Thank you for listening to my presentation so patiently. I'll like to have any questions if you have any. Thank you.
Thank you very much for that excellent presentation. Any questions from the floor? Can I start off by asking what neoadjuvant or adjuvant therapy do you use for these patients?
Well, these patients receive multiple different regimes. Because the data goes back to around 10 years, to started off with ECX, epirubicin, cisplatin. And now these days we are using flawed therapies for the patients we are considering.
And do you use response to chemotherapy as a means of selecting those patients for these multivisceral resections?
Yes, sometimes we do use that, but we obviously depends on the resectability of the patients. If they become resectable and we have a window, because now we are using the perioperative chemotherapy regimes. So that depends on whether the response is good or not.
Yeah, excellent presentation. Just one question about the high risk of recurrence, because you said almost 2/3 of the patients developed recurrence. So have you looked at any correlation with the nodal disease, because N1 or N2 disease and lymphadenectomy, what type of lymphadenectomy you do with those patients who developed recurrence?
So we try to D2 lymphadenectomy, which is around with aim for around 19 patients or 19 lymph nodes to be excised and check the nodal involvement. But we have not yet studied in the correlation between nodes and the recurrence in these patients, because as the sample size was a bit smaller, and there was already proven that the lymph node involvement is has proven to be good prognosis in the still operation.
Thank you. Any further comments, questions? Okay, thank you very much.
Thank you.
So let's move on to the next presentation by Arslan Pervez, talking about predictive factor for development of metacranial bladder TCC after nephroureterectomy.
Assalamu alaikum, everyone. My name is Dr. Salan Pervez, and I am a fellow in urology. It's basically uro-oncology department of surgical oncology at Shaukat Khanum Hospital. Today, I'll be talking about the predictive factors for the development of transitional cell carcinoma of the bladder, which occurs metachronically after nephroureterectomy for upper tract cancers. So I have no financial interests, arrangements, or affiliations to declare that would constitute a conflict of interest. A little background of the urothelial cancers. These transition cell cancers are the second commonest urological malignancies. And this is basically a field change disease, which can occur anywhere from the renal pelvis down to the urethra. Now, upper tract carcinomas, they account for only 5 to 10% of these urothelial cancers, and most of these tumors being occurring within the bladder. Majority of these patients basically present with visible hematuria, and pilocalyceal tumors, that is within the renal pelvis, are twice as common as those of the urothelial tumors. Now, the bladder cancers, it can occur either in a concurrent fashion, or it can occur metachronically, or in certain cases, it can precede the history of upper tract cancers. And 17% of the cases, there is a concurrent history of bladder cancer at the time of presentation. While following nephrectomy for upper tract cancers, the recurrence within the bladder is around 29%. And this is basically dependent on multiple factors, such as the tumor-related factors, the patient factors, or the treatment-specific factors. Now, the upper tract cancers, they are risk stratified into a high risk or a low risk disease, and multiple factors are taken into account, such as the focality of the tumor, the size of the tumor, the histological stage and the grade of the tumor, as well as their invasive nature on the basis of CT scans. In literature, number of prognostic factors have been proposed, and there is marked heterogeneity as to what are the factors which are basically causing the recurrence within the bladder. This, we in our study reviewed the demographic, the clinical, surgical, as well as the pathological data, and to look at the recurrence of bladder tumors, and reported the incidence of these bladder cancers as well as the predictive factors for the development of these tumors. We also studied the pathological stage and the grade distribution of bladder cancers following upper tract TCCs. So all those patients who were above age 18 and were presenting with a history of upper tract cancers and had nephrectomy at our institute, with both their radiologic as well as cystoscopic follow-up were included in the study. Patient who had a metastatic disease at presentation, as well as patient who had incomplete follow-up or who lost to follow were excluded from the study. So basically, it was a retrospective study, which was conducted at urology section in the Department of Surgical Oncology at Shaukat Khanum Cancer Memorial Hospital, where we looked previously for 5 years data using a consecutive sampling technique after getting the IRB approval for this study. So data was collected retrospectively from January 2019 till December 2023, and we had 71 patients who were treated with nephrectomy at our institute for upper tract cancers. So data was reviewed for demographics, clinical, surgical, and pathological data of these patients, and we assessed the univariate and multivariate analysis with logistic regression modeling to determine prognostic factors for the recurrence of bladder tumor. As for the follow-up, patient had regular cystoscopies for 3 monthly for the first 2 years, then 6 monthly for the next 5 years, and yearly thereafter with any yearly CT scans that were performed. So majority of our patients were male population, and with 50% having a prior history of smoking. The most common presentation was hematuria, which was seen in around 55% of the patients, followed by flank pain. Renal pelvic tumors, as previously said, are more common as compared to the lower or the distal uretary tumors. And in our study, we had 74% of patients who presented with a disease in the renal pelvis. Less than 10% of the patient had a multifocal disease at presentation, and there was a prior history of bladder cancer in patients prior to treating with nephrectomy in 13 patients. That is roughly accounting for 18% of the patients. Now, the pathological characteristics of these upper tract cancers following nephrectomy was that most of these patients had a non-muscle invasive disease, that is a PTA or a PT1 disease, with only 18% of the patient having a muscle invasive disease. As far as the grade of the tumors were concerned, most of these tumors were low risk or low grade tumors, with only 36% of the patient had a high risk disease or high grade disease at presentation. None of our patients had a variant histology. Now, 13 different variables were assessed as for the risk of development of bladder cancers following the management of upper tract TCCs. As you can see in red, the p-value that is significant is highlighted in the red. So 4 factors, that was the tumor size of less than 2 centimeter versus more than 2 centimeter, multifocality, as well as the location of the tumor, whether they are proximal or located in the distal ureter, and prior history of bladder cancers were the significant factors for prediction of for the bladder recurrences following nephrectomy, while rest of these factors were non-significant in terms of bladder cancer development. Now, the multivariate analysis were done for only those risk factors which were significant on univariate analysis, and an odds ratio as well as the p-value was accounted using a Cox odds ratio, hazard ratio, logistic regression. So the variable that was significant on the multivariate analysis was just the history of prior bladder cancers in these patients with a p-value of less than 0.05. The pathological characteristic of the bladder cancers that occurred following nephrectomy was majority were non-muscle invasive diseases, with only 2 patients that account for 8% of the patients having a muscle invasive disease. Just 25 patients, that is roughly 35% of the patient, or 1/3 of the patient, develop disease after management of upper tract cancers, and most of these patients having a low risk or low grade disease. So in conclusion, bladder cancers occurred in 1/3 of our patients following nephrectomy. Majority of these tumors being superficial with low-grade histology, with only the prior history of bladder cancers predicting the development of subsequent bladder tumors in patient with nephrectomy. So this high rate of early bladder cancer recurrences underscores the need for regular follow-up with regular cystoscopies and CT scans in patients after management of upper tract cancers. These are my references. Thank you.
Thank you very much. Are there any questions from the floor? Can I ask how frequently you follow these patients up?
So our follow-up regime is basically based on a high risk or a low risk strategy, and as well as on whether you have managed this patient for with nephrectomy or a kind of kidney sparing surgery. So if, as in our institute, we do nephrectomy for most of the patients. And for high risk patients, it's 3 monthly initially for the first 2 years, then 6 monthly for the next 3 years, consecutive years, up to 5 years, and then yearly thereafter, and with a regular CT scan yearly.
Any other questions? Thank you very much indeed.
Thank you.
Okay, thank you very much. Can I invite the next speaker, Zain Tayyab, who's going to talk about survival benefits after locoregional and liver resections in patients with stage 4 small bowel neuroendocrine tumors.
Assalamu alaikum and good afternoon. My topic is survival benefit after locoregional and hepatic resection in patient with stage 4 small bowel neuroendocrine tumor. Neuroendocrine tumor are basically heterogeneous group of neoplasm with variable morphology and biology. They can arise anywhere in the body, but most commonly from the gastroenteropancreatic tract. And annual incidence is about 3 to 5 per 100,000 population per year. Neuroendocrine tumors are basically indolent and slow-growing tumor. They mostly initially they present with lymph node and liver metastasis. 46 to 93 patients will be having neuroendocrine liver metastasis at the time of the diagnosis. As compared to adenocarcinoma of the small bowel, neuroendocrine tumor have better survival rate, and overall 5-year survival rate is about 61 to 77%. Objective of this study is to survival benefits of concomitant hepatic metastatic resection along with radical resection of the small bowel stage 4 neuroendocrine tumor. Methodology, this is the retrospective analysis. Duration of the study is about 10 years. Study was approved from IRB of Shaukat Khanum Hospital, Lahore. A total number of 70 patients with stage 4 small bowel neuroendocrine tumor, 21 had hepatic metastasis. 4 patients were referred from other hospital after resection of primary small bowel neuroendocrine tumor for the management of hepatic metastasis. Inclusion criteria is all the patients with stage 4 small bowel neuroendocrine tumor with 1 to 3 liver metastases. Total number of patients were included 15. The exclusion criteria patient having the comorbidities like CLD, CKD, and the dual malignancy. More than 3 liver metastases are also excluded from the study, and the number of patients were included in this. These are 6. Statistical analysis, statistical social science SPSS is 25, descriptive statistics, mean, median, and the frequencies. Median age is about 47, female were the 5, and the male are the 10 patients. Clinical presentation, they are both are the functional and the non-functional neuroendocrine tumor. 4 patients have the functional neuroendocrine tumors, and the remaining are the non-functional. Abdominal pain is the most common symptom presenting in our case series. Diarrhea and abdominal in 2 patients, and abdominal pain, melena and diarrhea in 2 patients, dyspepsia in 1, weight loss in 5 patients, vomiting in 5, and jaundice in 2, and carcinoid symptoms in 4 patients. Most common site of the primary is the ileum in 47% of the patient, followed by the jejunum in 27 patients, followed by the duodenum and the appendix in both every 2 patients. Degree of differentiation, the well-differentiated mostly are the well-differentiated neuroendocrine neoplasm. They are the 73%, poorly differentiated are the 27%. And well-differentiated further into low and the intermediate, and the low grade are basically the 37, and the intermediate is about the 63%. KI index is less than 2%, about 48% of the patient. Grade 2 to 20%, 26% of the patient. Greater than 20% is about 26% of the patient. Primary resection of the local region surgery, 15 patients. Small bowel resection in about 9 patients, with right hemicolectomy in 4 patients, and Whipple procedure in about 2 patients. Liver resection, most common site of the metastasis is the right lobe. In left lobe, 2 patients having the left lobe metastectomy, bilateral mastectomy in the 3 patients, non-anatomical liver resection in 3 patients, right lobe segmentectomy in 4 patients, and right lobectomy in 3 patients. Adjuvant treatment, octreotide in the 6 patients, and chemotherapy 5 patients, and octreotide in chemotherapy both in the 4 patients were after the surgery. Survival mortality, 30-day mortality in 1 patient, 90-day mortality in the 2 patients, 10-year overall median survival is 54 months. 8 patient, 10-year follow-up, median survival is about 88 months. 7 patient, 5-year follow-up, and median survival is about 44 months. This is a graphical representation of first patient having surviving for 7 months, and last patient is about 9 months. Continuous small bowel neuroendocrine tumor is a good tumor of the good prognosis. Patient with small bowel neuroendocrine tumor localized or metastatic should be managed at experience center by multidisciplinary teams. Surgery of small bowel neuroendocrine tumor and liver resection has survival benefit. Study was limited by its retrospective design. We acknowledge the support provided by the statistical department, Shaukat Khanum, granting us valuable data of the patients. These are the reference.
Thank you for a very clear presentation. Are there any questions from the floor? Mike.
Both biochemically and investigation. Biochemically, we do the urinary 5-hydroxyindolic acid test, and by DOTA stain and CT to initially pre or workup for the patient.
Just wondering whether you also check for any cardiac dysfunction with NT-proBNP or
Some patient will have to see the carcinoid symptoms, echocardiography to rule out any cardiac symptoms.
so you go straight to echo. Yeah.
Yeah.
Okay. And how did you choose patients for chemotherapy? Just for the audience, really.
Patient will have poor differentiation, KI index. Patient will have G3 and those tumor on histopathology, lymphovascular invasion, and number of lymph nodes to yield during local regional surgery.
And the follow-up,
Follow after 3 months, and as NCCN guideline, 3 months followed by the 6 months, and then 1 year annually.
Can I ask you a question that why did you exclude patients with more than 3 liver metastases from the study?
Residual volume of the liver is greater than 30% is required. In most of the patient, after resection of the liver, 30% residual volume is not left.
But that was excluding criteria was number of liver metastases, and more than 3 were excluded. So why was that?
It is retrospective study. We saw the patient, those who have greater than 3 liver metastases were not included in resection.
Any more comments? Okay, thank you very much. Right, can I invite the next speaker on the floor, which is Sabiga Amon talking about impact of positive resection margins after gastrectomy and recurrence and overall survival in patients with gastric carcinoma.
Assalamu alaikum. My name is Dr. Sibgha Ayman. I am Fellow Surgical Oncology in Shaukat Khanum Cancer Hospital. So my topic for today's presentation is impact of positive resection margin after gastrectomy on recurrence and overall survival in patients with gastric carcinoma. I have no conflict of interest to declare. So gastric cancer is the fifth most common cancer and leading cause of cancer-related death worldwide. In Pakistan, the stats are gastric cancer is the ninth most common cancer, and it is eighth leading cause of cancer-related death. It is more common in males. There are multiple risk factors associated with gastric cancer. These includes H. pylori, genetic mutations, diet, smoking, and obesity. And because of these risk factors, Asia has the highest number of gastric cancer and subsequently highest mortality, which is 70.1% in comparison to Europe. In Europe, it is 14.5%. So overall survival, especially in locally advanced cancer, has improved significantly with perioperative chemotherapy. Surgical resection still remains the mainstay of treatment after perioperative chemotherapy with intention of cure. Positive resection margin after curative intent is found to be a poor survival outcome and early recurrence. However, there are multiple studies that suggest there is no significant value in this. So our objective was to determine the recurrence rate in patients with positive resection margin on histopathology and compare it with patients with negative margin, and to determine the overall survival and recurrence-free survival of patients with positive resection margin compared to patients with negative resection margin. This study was a retrospective cohort study conducted in Shaukat Khanum Memorial Cancer Hospital from January 2019 to December 2023 and was done after IRB approval. The inclusion criteria was a patient included age 18 years and above and diagnosed with gastric carcinoma, underwent gastrectomy as elective case for curative intent, including patients with multivisceral resection. Exclusion criteria was patients with gastric carcinoma, but surgery was not performed or surgery was done for palliative resection, and malignancies other than adenocarcinoma, such as neuroendocrine tumor and GIST, was also excluded. We included 219 patients. The total number of patients was 303 and exclusion was 84. Out of these 84, 42 was palliative resection, 15 patients had GIST. Neuroendocrine tumor was found in 12 patients and irresectable for 15 patients. Statistical analysis were performed using SPSS version 26 and categorical variables were analyzed using frequency, percentage, and mean. The association between two categorical variables was assessed using chi-square, and survival analysis was conducted using Kaplan-Meier curve. These are the baseline surgical characteristics. Our patient mean age was 48. Male to female ratio was significant, 2:1. BMI was mostly normal weight. Site of disease most common was in distal stomach. Pathology most common was intestinal type of adenocarcinoma, which was 63.1%, and 48.9% had poorly differentiated carcinoma. Plot was the most common regime given to this patient, which was 60%, and most common procedure performed was total gastrectomy in 58.4% of the patient. Multivisceral resection was performed in 14 patients. In our study, T3 was in 51.3% of the patient, and NOT was achieved in 38.8%, and N3 had 21.5% patient. 25 patient had complication, but Clavin-Lido class 3 was in 7 patients only. So in margin status, we have 89.9% with negative margin, and positive margin was present in 10% of this patient. Out of these 10%, majority had proximal margin positive, which was 16 patients. In recurrence, 55.3% of the patient did not had any recurrence. Out of 44.7% patient who had recurrence, 14.2% of these patients had positive margin, and the rest of the patient had negative margin. There was no specific significance in recurrence versus margin. The p-value was 0.06, which is statistically insignificant. In relation with T-stage to the recurrence, we found that the patient who had a higher T-stage are more prone to recur, and the p-value was significant with 0.001. In nodal status, the more the nodes involved, the higher the chance of recurrence with significant p-value. In poorly differentiated and diffuse type of carcinoma, the similar results was achieved with statistically significance. The higher the grade, the chances of recurrence are high. So overall survival, we had 17% mortality in our study, and 5-year survival rate is 65%. 4-year survival rate for patients who had margin negative was 71.3%, and for margin positive patient was 66.7%. Recurrence-free survival in patients in 5 years was 38%. Majority of the recurrence was observed in under 2 years. So margin positive in these patients survival estimated is 43%, and margin negative survival is 54%. We were unable to see a statistical significant analysis with the p-value of 0.06. So the basic conclusion was the positive resection margin is a poor prognostic factor for patient with gastric carcinoma in respect to recurrence, but it does not have a outcome on survival benefits. Intraoperatively, we should make maximum effort to achieve negative margin to avoid recurrence. We found that the tumor stage, positive nodal status, and poor grade are the predictive of recurrence. Thank you.
Thank you very much. Any questions from the floor? Can I ask, how did you treat the positive resection margins? Did any of them go back for further surgery?
Yes, so this is a separate study we are conducting, that those patients who had positive margin were surgery were done in these patients, or were these patients managed via chemotherapy. This is a separate analysis. So few patients did underwent surgery for positive resection margin, but majority of the patient underwent localized radiation therapy, and separate subgroup underwent adjuvant chemotherapy.
And was there a greater, I might have missed this, was there a greater risk of positive margins in the subtotal gastrectomies compared to the total gastrectomies?
No, basically total gastrectomy, we had a positive proximal margin more relative to the other margin. So the more total gastrectomy was performed, so positive margin was positive more in total gastrectomy. So the proximal margin is positive, meaning the total gastrectomy patient had a more margin in it. Okay, so our margin positivity is relatively much better than the published data. So in literature, it has been reported the acceptable in gastric cancer studies. So it's up to 35% for overall margin positivity rate. And for proximal margin specifically, it's up to 15%, 10 to 15% is acceptable. So for our cases, we had a 7.3% proximal margin, and overall combined margin was only 10%, which is very good margin. So in patient, there is no survival benefit in recurrence-free and overall survival for patient who had a margin compared to the negative margin. But there is a difference in recurrence. So patient who had positive margin did had early recurrence in relation to those who had negative margin.
Can I ask one question? You have included circumferential margin in the study already, which are not surgical resection margins. Do you think excluding them will change the result of your study?
No, because only 3 patients had circumferential radial margin positive. So I don't think these will put an impact on the overall outcome of the study. Yes. Sure.
Correct me if I'm wrong, but I think when you look at your margin positive, margin negative survival, you said the value was 0.06, statistically insignificant. So do you think that if you had a bit more sample size, it might show significance?
Yes, yes. And plus, we are doing that. We are taking the 10-year now. This was the 5-year study. So we are proceeding it to 10 years, and to see that if we can found a better outcome after 10-year analysis. After 10 years. That's it. Thank you.
Okay, thank you very much. Good. Can I invite next speaker on the floor, which is Muhammad Anis bin Akhtar, talking about textbook outcomes of pancreatic adrenectomy for adenocarcinoma of the pancreas in a high volume center.
Good afternoon. My name is Dr. Anas. I am fellow surgical oncology. The topic of my presentation is textbook outcomes of pancreatic adrenectomy for adenocarcinoma of pancreas in a high volume center. So I have no conflicts of interest to declare. So pancreatic adenocarcinoma is the sixth leading cause of cancer death in Pakistan, as its incidence is increasing. Pancreatic adenotomy is the standard surgical treatment for pancreatic adenocarcinomas, but achieving optimal outcomes remains challenging. High volume specialized centers associated with better outcomes due to specialized expertise and resources. Individual parameters like mortality, morbidity, hospital stay, readmission, and complications might not capture the complex recovery process in pancreatic adenotomy patients. So the idea developed the text root outcomes. It is a composite parameters of a quality. It might be superior to individualized outcomes and parameters. An optimal outcome is achieved when all of these parameters are met in a single individual patient. This is all-on-one approach, substantially improves the patient care, potentially reduces the healthcare cost, and forms the basis of newly proposed term textbook outcomes in surgery. So the aims and objectives was to measure the textbook outcomes of pancreatic adenocarcinoma in a high-volume specialized center of the country. So here are the 7 textbook outcomes, starting with negative RO resection margins, greater than 12 lymph nodes examined, no prolonged hospital stay greater than 14 days, no ICU treatment, no 30-day readmission or mortality, no postoperative grade 3 or above complication, no pancreatic fistula grade B and C. So if all of these parameters met in a single patient, then the textbook outcome of that individual patient is met. So it's a retrospective analysis for the last 6 years, starting from 2018 till 2023. It was conducted at our hospital, Shaukat Khanum, Lahore. So the patients who underwent pancreatic adenotomy for adenocarcinoma of pancreas, the exclusion criteria of the patient was that missed the necessary information from all the textbook outcomes like resection margins, lymph nodes, ICU treatment, tumor differentiation, or body fluid amylase. Patients with histopathology of pseudopapillary tumors and neuroendocrine tumors were also excluded. This is the sample size showing 257 patients in total 6 years. We excluded 57 patients, in which 47 had histopathology of neuroendocrine tumors, 6 had duodenal cancers, 4 had pseudopapillary tumors, and we included total of 200 patients. So this is the gender-specific results. 65% of patients were male and 34 were female. Most of the patients had ECOG status of 1. Most of the patients had ASA score of 2 before surgery. 37 of the patients developed pancreatic fistula. So before I go to my results, I must mention 3 centers that have done research in this textbook outcomes. So number 1 is US, that have concluded their last 10 years data, and they have only taken 3 textbook outcomes. We have taken the 7 textbook outcomes, and their total textbook outcome is around 16%. The next is the Chinese research. It's a 10 years analysis. They have taken all the 7 textbook outcomes that we have taken, and its results are comparable to us. The last one is the systematic review published in Germany for the last 15 years, including 30 studies, and their textbook outcomes is around 24%. So coming on to the individual textbook outcomes. So this is the Chinese study comparable to our study. This is the blue bar is our study at our Shaukat Khanum Hospital, Lahore. So we had achieved 94% of negative resection margins. 95% of patients had greater than 12 lymph nodes healed. Only 5% of patients had ICU stay, and only 15% of the patient had prolonged hospitalization. 11-3 classification, only 12 patients had 3 or greater than above 11 mortality complications. Only 2 patients developed pancreatic fistula B and C. 30-day readmission was only 6, and 30-day mortality was only 6. The orange is comparison with the Chinese research. So overall textbook outcomes of our center is 61%, which is marvelous compared to US, China, and Germany, 16, 24, and 38%. So our institute has achieved very high textbook outcomes as compared to the international centers. This depicts multidisciplinary patient-centered care at our institute. References. I'm open to questions and comments.
Thank you very much. Any questions from the floor? Yeah.
So, yeah. So I think we are doing this pancreatic surgery from last 25 years, and our ICU care, multidisciplinary approach, NBT meetings, and patient-centered care is good. So I think that's the biggest thing behind these outcomes.
Right, I've got a question. You compared it with the study which has got 20% mortality for pancreatic duodenectomy, which is unacceptably high.
Yeah.
So that is one comment that comparison doesn't look right. But a few questions. One is, what do you define as a high volume center?
The center who is doing around above 25 cases per year is a high volume center.
Right. And second is, why did you exclude a number of patients who had non-cancer diagnosis?
Our textbook outcome was to achieve oncological resection. So the first point was greater than 12 lymph nodes achieved. So in benign diseases, for example, pseudobiliary tumors or neuroendocrine tumors, we don't go for harvesting more lymph nodes. So that's why we excluded those patients from our study. Yeah.
Just a question regarding how we stage your histopathology. How many histopathologists actually do your reporting?
Sorry?
How many histopathologists do your reporting in your group?
We had around pancreatic adenocarcinomas.
How many different pathologists do you have doing your reporting?
Around 6 or 7, I think. Total number of histopathologists.
Okay, thank you. I have a question. I mean,
Yeah.
so very good numbers and it's very good results and it's for a couple of years as well. So, could it be that your results are better given the patient selection that you have as opposed to all others? I'm sure the Chinese do MDT as well and the Europeans do MDT as well and so forth. Now, is there any age limit to the kind of patients you take? And could it been that your patients are at a much fitter group compared to the other centers?
Yes. Most of the patients had ECOG status of 1, but our exclusion criteria was not about that. We included all the patients, all the age groups, all the ECOG status. But in our results, around 65% of patients had ECOG status of 1. Maybe that's the reason behind good outcomes of our research project.
Do you also have an ERAS program and rehabilitation?
Yeah.
I mean, your results are exceptionally good, and I must commend you for presenting this data. It'll be really helpful if you also do this prospectively.
Yes.
Because that would be far more appreciated and a more compelling story to tell.
So now we have started collecting the data from the start, from 1996 till date. This is the next project, and we will hopefully do that prospective analysis as well. Yeah.
Maybe we can learn a few things from you.
Yeah, sure. Thank you.
Okay, thank you very much. Right, so we move on to the last presentation of the session, which is by Mahnur Asim, talking about day before major oncological surgery admission. Do we really need them?
Focus. Yeah. I apologize. My colleague couldn't make it to the time, so I'll be presenting in behalf of her. I'm Dr. Rakas, surgical oncologist in Peshawar. So today we'll be talking about day before major oncological surgery admission. Are they really needed in 2024? So let's find out. Sorry. So what is a day of surgery admission DOSA actually? Day of surgery admission, traditionally we admit our patient day before surgery to make sure they are available and no mishaps happen to delay our surgery and cancel our surgery on the day of surgery. So what is DOSA and why DOSA is the need of hour? As we are working in a resource poor country and increased burden on the healthcare facilities and finite number of hospital beds available in our setups. So we think we need our DOSA approach to make it happen and easy for a hospital. And so it's also the part of enhanced recovery protocols after surgery. To understand DOSA better, let's talk about the component of DOSA. So as the patient come to us for the surgical OPDs straight from the MDT, we review our patient and analyze whether this patient can be a part of the DOSA or not. And then identification of the correct patient. We then refer a patient to the anesthesia for pre-operative evaluation and optimization. After that, we do the proper education of the patient regarding the day of surgery admission, and then patient communication and education provided to the patient. And then we call our patient to come timely arrival to the holding bay and MRSA prophylaxis, SSI prevention bundles, and all the education being provided to the patient in the OPD. So basic components of the DOSA is ERAS components, and the counseling of the patient is very important step in this. We do counsel our patient that has to be arrive on the time to the holding bay, follow all the SSI prevention bundles, and then the rehabilitation, including nutritional optimization and support, and then addressing the comorbidities. If we look that we are also including our colorectal team in this, so we also give the education regarding the stoma and bowel preparation where needed to the patient in colorectal surgeries. Let's talk about the objectives. Whether we looked whether the DOSA is implementable, safe and sustainable, and its cost effectiveness though. And we analyze and look at the outcomes of the DOSA approach. So we concluded this study in 3 prospective study. We taken the patient from April 2020 to April 2024. The inclusion criteria were all the cases who underwent elective oncological surgeries, and inclusion criteria or emergency surgeries. Those patients with comorbidities need preoperative admissions, and those patients who were unable to understand the instruction being given. So how it started? We did started our study as the pilot study from HPB. Then we entered the pre-DOSA HPB. And then phase 1, we included our colorectal fellows. Then we included in phase 3, we included upper GI team. So how we started? We started our pilot studies from day case laparoscopic cholecystectomies and sustainability. If we look at the pilot study, total of 24 patients underwent day of surgery admission, and 14 patients were preoperative admitted. And if we look at their outcome, they were not so different. So if we look at our numbers and prevalence, total of more than 1,400 patients underwent this approach. And overall prevalence, if you look at 2021 and then at 2024, we started at 54% in 2024, and now are almost at 80%. So if we look at the outcome and results, our 90-day mortality was 0.2% in only in 3 patients. The most important question in this area is cancellation on day of surgery. Is we have seen 17 patients being canceled, unfortunately, for day of surgery, morbidity being recorded in only 2%, and readmission rate was only 1% in all of these patients. The most important topic to discuss, the cancellation, why the cancellation happened. If we look at the cancellation divide into medical and non-medical reasons, so only 10% being canceled for the medical reasons, and 7 patients did not show up for the surgery on day of surgery. If we further categorize it, medical reasons were uncontrolled diabetes, hypertension, and only 2% patient had positive pregnancy test which been canceled on day of surgery. So complication were almost 2%, that included 8 patients in ostomotic leak and 22 patients of SSIs, surgical site infections. And if you look at the financial efficacy of the DOSA approach, since we started, we have saved almost more than 25 million rupees for our Shaukat Khanum Peshawar on this project. We done a patient satisfaction survey from May 2022 till May 2023, which included 41 patients, and we found that it's a patient satisfaction ratio was very high, almost 100%. So if we come into the conclusion and discuss that whether DOSA, yes, DOSA is safe, it's cost effective, sustainable, and we do have some high satisfaction among our patients. We do have some limitation of cultural belief of a patient on the preoperative day admissions and reluctant to change the prevalent practice among the surgeons. Our future direction is to encourage the adoption of day of surgery admission approach among the surgeon from different specialties as a common practice. This is the picture of our lovely team working day and night to make sure this project goes on. Thank you so much.
Agree. What a lovely team they are.
Thank you.
Any questions from the floor? Can you tell us a bit more about resistance from colleagues? Was that the older generation or the younger generation?
The age difference did not matter that much, but the language barrier was the most finding thing. We weren't able to convince the patient to come on the day of surgery in the morning and show up. Some patients were coming from far away. They were.
And my question was about your colleagues, about
Yes.
the consultants. the
Yeah, so
surgeons.
our team is led by our own very experienced HOD, Dr. Sayyidin Farooq Kabir, and been looking very closely into it. So.
But I remember when this was introduced in the UK years ago, there was a lot of reluctance and no one believed it was ever going to work. And of course it did. But there was a very clear correlation with the age of the consultant, I think. Yeah.
Sorry, it's fantastic. I failed to look at what proportion of your patient within DOSA group had bowel preparation, because that is one of the rate limiting factors, asking people to take it at home and their compliance rate. That's the first comment. Secondly, it's about 1,400 cases you showed.
Yes, sir.
And your patient feedback survey is from sample size of 41. Do you think?
Yes, it's a
improve bit?
prospective study. It's still going on, and we're looking in the future to
I think I know the answer to this, but I thought I'd ask it. You had 1,400 patients and your readmission rate was about 1%. These 1,400, were they all comers or were they all major surgery?
yeah, they both major and minor oncological surgeries.
Because a 1% readmission rate is also very impressive.
Yeah, that's the finding.
Thank you very much.
Thank you so much. Thank you.
There is actually one more presentation left, and I've been just given the topic. It was missing from the list. So it is Sharkhil Sarshar talking about role of AI in head and neck cancer surgery. And that will be the last presentation for the session.
Assalamu alaikum. I am Sharkhil Sarshar. I am a resident general surgery from Shaukat Khanum, Lahore. All technology is an extension of some human faculty, psychic or physical. The wheel is an extension of the foot. The book is an extension of the eye. Clothing is an extension of the skin. In the same vein, scalpels and AI is also an extension of surgeon's hand, mind, and brain. So the topic of my presentation is the role of artificial intelligence in head and neck cancer surgery, current advancements and future prospects. Artificial intelligence significantly impacts head and neck surgery across various domains. Key benefits include early detection of disease, prompt and effective treatment, improved perioperative care, and reduced medical errors. Limitations and ethical concerns persist, including skepticism, patient privacy issues, and the need for regulatory frameworks. The ability of digital computers or computer-controlled robots to perform tasks commonly associated with intelligent beings is termed as artificial intelligence. These tasks include, but are not limited to, learning, perception, problem solving, and reasoning. Machine learning is a subset of artificial intelligence, and it uses statistical methods to enable machines to improve with experience. Deep learning is a further subset of machine learning, which allows computation of multi-layer neural networks feasible. This is the diagram of an artificial neural network. It works just like the human neurons do. There is an input layer which feeds data into multiple hidden layers. The data is then processed in these multiple layers and an output is generated. So this is how the machine learning process works. The training data is fed into the machine learning algorithm, and then the model input data is used to make a machine learning algorithm, and this is used to get various outputs. So this model is then validated with a new set of data, and the output is generated, which is then evaluated. If it's up to the par, then it's a satisfactory model. And if it doesn't work as expected, then the machine learns itself and improves with time. So what is the role of artificial intelligence in head and neck cancer surgery? In pre-operative phase, it is used for the diagnosis, imaging analysis, electronic health record analysis, risk assessments, and personalized treatment planning. During surgery, real-time decision support can be used. Surgical robots are being used, which may or may not be combined with the augmented reality. It is also used for education purposes. It is also post-operatively, it is used for prognosis prediction, survival rates prediction, complication rates, and monitoring. So this is an instance of how machine learning is used to automate the detection of oral cavity squamous cell carcinomas from photographs. So some researchers used some 6,000 intraoral normal and biopsy-proven oral squamous cell carcinoma photographs, and it was used to train the machine learning model. And the model was later on validated by a set of clinical photographs from several journals, and the output was generated. And the sensitivity and specificity of the model was really high. In preoperative phase, machine learning analysis can identify suspicious oral lesions from autofluorescence imaging, white light imaging, and it has a potential for a mobile health device as a powerful triaging tool for identifying suspicious oral lesions with 82% sensitivity. So artificial neural network also allow the detection and classification of features on panoramic radiographs and cone beams CT images. Among these features, radiolucent bone lesions of the mandible and maxilla are the most studied. In this example, a machine learning model could accurately identify dentigerous cyst and amelioblastoma from the given panoramic radiographs. So AI can also be used for the purpose of disease staging. Some scientists used a 3D CNN model, trained it on some 3,000 CT segmented lymph nodes from 124 samples with pathology labels, and tested it on a set of 131 samples. Accurate prediction of extranodal extension and nodal metastasis could be done, and the accuracy was better than expert radiologist. In the images this is the original image of the CT scan, and this is the image where AI model could accurately mark the metastatic nodes and the normal nodes. So surgical robots are also being used with the benefits of low complication rates, greater precision, faster recovery, reduced post-surgery pain, better maneuverability, increased time, increased cost. Augmented reality is also being used, and it can help in overlaying the radiographic imaging data in real time during the surgery. So these have advantages of enhanced precision, reduced surgical workload, and avoidance of critical structures. This is also an example of how an AI model was used in a cadaveric experimental study. So the model used for the augmented reality was used over a 3D reconstructed model that was segmented, and it was later on in surgery. The surgeon could identify the internal carotid artery through his console. In post-operative phase, complications and mortality has been predicted with accuracy using electronic health records. Another study identified patients at high risk of extended hospitalization with accuracy levels of up to 97.92%. Such predictions are based on factors such as operative time, ischemia duration, ASA scores, intensive care duration, and TNM stages. So these are the challenges limited knowledge about fundamentals of AI in surgeons regarding reliance on AI for clinical decision making. There is mistrust and skepticism. The curriculum is outdated. The data used to train the machine learning model are low quality data, and data annotations of large volume of surgical videos manually is a daunting task. So this is the way forward. This is Levin's change model used to define an organizational change. You first have to unfreeze the previous norms to become motivated to change. And then there needs to be some cognitive restructuring about what needs to be changed. And then new norms are established and they are refrozen to make the change permanent. Thank you. Any questions?
Many thanks for that. Any questions from the floor? Yeah.
Thank you very much. It appears this is a hot topic now in most specialties, and you've just presented head and neck version. Most of the interpretation going to AI at the moment is data interpretation, which is looking at the data and coming up with what they're looking at in terms of machine learning. There is a limitation in automation, as you suggested. Why do you think is that the case so far? Because the computing have improved a lot. Why there is, you look at flying, for example, there is almost everything down to automation now, flying a commercial airliner. In surgery, there is a limitation.
So far, the automation is concerned, now we are at that stage of the technology that we are going to have some semi-autonomous robots that could perform surgery based on the surgeon's decision. What I mentioned in my presentation was the problem with data annotations, where you have to label large volume of videos, and you have to actually teach the computers that what is the structure being shown in the video. And then later on, when a new video is shown to the computer, it could accurately identify that what is being going on in the video.
So do you think when you read through this, that would surgeons ever become redundant, or would the surgeons who fail to work with AI would become redundant?
I would go with the second option, that we have to adopt with the technology, that sooner or later it's going to be the norm, and we have to follow it. And
Yes.
Yeah.
Thank you for talk. Again, fascinating. I think you highlight the advances that have been made with data interpretation and also in diagnostics, where AI is likely to make a big impact. We also spoke a bit about robotics and augmented reality working into our practice. How do you propose that we prevent industry driving this process forward versus us looking at evidence and then taking on new technology?
so that's the problem adopting these technologies, that there is a lack of collaboration between several industries. We need to collaborate more with the other industries, for example, computer sciences and the experts that know how artificial intelligence works and how robots works, because they don't have sufficient knowledge about surgery and clinical knowledge about, they don't know what to interpret from the data. They don't know what they have to make, what kind of machines they have to make that could benefit surgeons. So this is, and the surgeons lack the knowledge about the artificial intelligence, and they don't know how these things work. So there needs to be some big collaborative efforts to drive the change. And I think that's the way forward.
In your presentation, when you talked about robotic surgery, you sort of said you rolled off all the benefits, better outcomes, shorter stays, reduced complication rates. Do you really think that's true?
Yeah, I think the literature shows that.
Does it? Maybe, are you talking about head and neck surgery, or are you talking about generally?
I'm talking about both.
Okay.
How do you see AI being applied to healthcare system in Pakistan, especially in your specialty in future? So there are two ways of doing it. One is buying the technology from somebody, and second is developing our own technology. I think as a country, we are far ahead in IT development. But how do you see the collaboration working?
A few months ago, our hospital acquired a program that could label the X-rays of the patients, and it was they probably bought it from some international company. But all the young generation that wants to learn artificial intelligence and these things, they have to go abroad to study this, and then they do stuff for the other countries. They don't come back. So I think
Right, just a comment really. I'm aware of at least 4 universities in Lahore who are working on artificial intelligence, both in pathology and radiology, but they
Yeah.
do not have access to clinical systems. So I think that's where we have to work collaboratively with them and give them what you have already mentioned, input from clinician side, and help them develop those systems.
So,
So just a comment.
So I just saw a poster that is being presented in this symposium, where some researchers from 3 universities of Peshawar collaborated and came up with a machine learning model that could predict the histopathological slides. So that's the kind of work our people are doing here. But yes, we need to collaborate more with universities, other universities, and the hospitals need to be making more regulatory framework that could regulate the transfer of data and how that data is being used.
Thank you. That's a great session from all of you. So thank you to all the presenters and really high quality work.
Assalamu alaikum, Dr. Amir from radiology, and especially I'd like to introduce Dr. Asif Mateen, our most senior radiology consultants. Inshallah, he will share this session. Or so this session is regarding free papers. The first talk is of Asma Manzoor from SIUT, and she will present on the role of FDG PET-CT for lung cancer, Hopkins criteria based approach to the therapy response. So everyone has got 10 minutes. So please adhere to the timeline so that we can conclude on time. Dr. Asma Manzoor.
Only the opening things and let us know.
Any idea who is keeping an eye if she's online? कौन facilitate करेगा online हो? Okay, so she's not here, so we can move to the next one, and if she comes, yes, we'll accommodate her. So the next one is Dr. Kiran Irshad. Is she here? Okay, so her topic is detection of primary HCC. Dr. Kiran Irshad from Fatma Memorial Medical College and Hospital, FMH. So, Dr. Kiran, welcome, please.
Assalamu alaikum. I am Kiran Arshad from Doctors Hospital, and the topic of my presentation is sensitivity of 18F fluorodeoxyglucose positron emission computed tomography for the detection of primary hepatocellular carcinoma. In our presentation, we will discuss about introduction, our objective, material and method, results, and conclusion. According to Global Cancer Statistics 2022, HCC is the 6th most frequent cancer and the 3rd most prevalent malignancy, contributing to cancer-related death on the global scale. According to GloboCan 2022, HCC is the 8th most common cancer in Pakistan. HCC is 5th frequently diagnosed malignancy in males, while among female it ranks as the 7th most common malignancy. The Emerson grading system is mostly used to classify HCC into the 4 different histological grades, that is well, moderate, poor, and undifferentiated HCC. Around 60 to 70% of HCC cases diagnosed at moderately differentiated and poorly differentiated stage. And the diagnosis of well-differentiated HCC often delayed due to the lack of symptoms and also due to the lack of awareness. International guidelines for HCC, International Atomic Energy Agency, and National Institute of Health suggested these recommended tests for the detection of hepatocellular carcinoma. There are some restriction in the pathological analysis of HCC that these tests does not reveal. Like identification of HCC on ultrasound remains challenging because liver show the area of fatty infiltration and nodular regrowth. MRI and CT is the technique of choice for the detection of primary hepatocellular carcinoma. Its sensitivity is reported to be 100% for the diagnosis of hepatic lesion, but the sensitivity reduced when the lesion is less than 1 to 2 centimeter in size. So these three imaging modality give detailed information regarding the tumor size, tumor morphology, but does not give us information how's the tumor functioning. So FDG PET-CT is a nuclear medicine imaging modality that gives the structural and the functional information of HCC at cellular level. FDG PET-CT is used for the diagnosis of HCC, also used for histological HCC distinction, also used to monitor therapeutic response, and also used to detect reoccurrence of disease. FDG PET-CT also detect intrahepatic and extrahepatic metastasis in single scan. The prevalence of HCC has shown to be as high as 80% in the region of Southeast Asia and Africa. The current study population is situated in area where there is a higher incidence of hepatitis C virus, and hepatitis C is one of the most prevailing cause of hepatocellular carcinoma. Due to the lack of symptoms and awareness, only 8.2% patient in Pakistan receiving diagnostic test for the detection of cancer. And unfortunately, there is no single data available from Pakistan regarding the utilization of FTG for the detection of hepatocellular carcinoma. The detection of primary hepatocellular carcinoma on FDG per CT still remain challenging because to the elevated level of higher FDG uptake in the liver parenchyma. So the objective of my study is the sensitivity of 18 FDG per CT for the detection of primary hepatocellular carcinoma. This prospective study comprised a cohort of 51 patients who diagnosed with HCC and underwent FDG per CT scan from May 2022 to December 2022. Individual who meets the eligibility criteria were the adult patient who already diagnosed with HCC and the patient presented with recurrent HCC. In our research, 20 patients has HCC verified on histological examination, and in 20 patients, HCC was verified on CT scan, and remaining 10 patient HCC was identified on MRI. Our sample size not included the patient having the malignancy other than hepatocellular carcinoma, and we not included pregnant and lactating women in our study. PET-CT image processing and acquisition including following step. Firstly, patient history was documented, and then after administering the dose of 7 to 8 megabecquerel of per kg of body weight, FTG PET-CT scan was performed after 45 to 90 minutes, and then following the reconstruction of PET and CT data, sagittal and coronal images were reconstructed. Standardized uptake value. The PET-CT images were analyzed for the hepatic lesion. The use of SUV max value allows us the quantitative analysis of both the hepatic lesion and FTG uptake. So by applying directly SUV value around the region of interest, we can calculate the higher metabolic activity value and SUV max. The term hypermetabolic is used when there was a detected rise in FTG uptake as compared to surrounding liver tissue, and term hypometabolic is used when there was decline in FTG uptake as compared to surrounding tissue. In our research, HCC patient, where the HCC was diagnosed on CT scan, MRI, as well as on FTG per CT scan, were diagnosed as true positive for malignancy, and the patient who exhibit positive finding on CT, MRI, and histological examination, but negative finding on FTG per CT were mediated to have false negative outcomes. In our research, 78% patients were male, 10% patients were female, and the mean age of patient was 51. Among the cohort of 51 patients, HCC was diagnosed on FTG per CT scan in 43 patients, representing the true positive result. While in 8 patients, HCC was not diagnosed on PET CT scan, representing the false negative outcome. 74% patient represented with multifocal HCC that involving several liver segments, while 25% patient represented with unifocal HCC involved only single segment. So our research also revealed metastatic disease in 28 patients, where the abdominal lymph node metastasis and skeletal metastasis were the two most prevalent extrahepatic sites for the metastatic disease. And in our research, 4 patients represented after the treatment, and FTG per CT revealed tumor reoccurrence in 4 previously treated patients. FTG uptake value is one of the most reliable indicator for the existence of tumor. So the maximum standardized uptake value of malignant site range from 1.9 to 16 and with the mean value of 3.7. Segment 8 is the most commonly involved segment of in all the hepatocellular carcinoma cases, while segment 1 and segment 2 exhibited the lowest frequency with the incidence of 2 and 3%. And segment 4 has the higher FTG SUV max value, and FTG uptake in the segment 4 has statistically significant. So the sensitivity of 18 FTG PET CT for the detection of hepatocellular carcinoma was 84.3%. By using this formula, we calculate the sensitivity, and this figure of PET CT scan demonstrate the hypermetabolic hepatic lesion that indicated the hepatocellular carcinoma. Accumulation of FDG in hepatic lesion depend on the tumor metabolism. Lower grade HCC has a lower glucose metabolism and lower FDG uptake value, while higher grade HCC has a higher glucose metabolism and higher FDG uptake value. So our study concluded that FDG per CT is a valuable imaging modality for the detection of higher grade HCC, but FDG per CT is not valuable imaging modality for the diagnosis of primary hepatocellular carcinoma because of physiological pattern of higher FTG uptake in normal liver parenchyma and the fact that well-differentiated FTG uptake value is analogous to that of normal liver tissue. So FTG per CT is not a useful imaging modality for the detection of primary hepatocellular carcinoma. Our study has limitation that sample size is small, we included positive patient of HCC, and it is expensive imaging modality. Thank you.
Shukriya. Just about what you have mentioned, when we talk about cross-sectional imaging in CT and MRI, as you mentioned, I think it was a better idea if you would have added that we require triphasic CT and triphasic MRI. That is important. That is the only way we can diagnose HCC. So good presentation. Well done.
Thank you, sir.
Thank you very much. Sorry, one more question, please. Sorry. I'm just wondering, looking at your topic, so your topic was, sorry, apologies. Yeah, so detection. Yeah, fair enough. So if a patient will come, what modality you will offer to them? For example, if a young patient, will you offer PET CT the first instance or will you go for MR?
The patient age?
No, for any patient, for example, a 40-year-old patient, if he comes, will you go for PET CT or at the basis of your study?
Sir, if patient come for PET CT scan and a very young age, firstly, we will confirm about the pregnancy status. If the patient is not pregnant, then and other previous imaging modality like CT and MRI reveal the diagnosis in these imaging modality, then we would not perform FTG PET CT scan in young patient. And if these other imaging modality like CT and MRI does not reveal the diagnosis, and if pregnancy status is confirmed that patient is not pregnant, and then we would perform FTG PET CT scan.
All right, thank you very much. Your question? Sorry.
Question है मेरा इनसे आपका जो inclusion criteria था, you included all those patients which were already diagnosed with this.
Yes, sir.
Isn't it biased?
Yes, sir.
That becomes biased itself.
सर यही हमारी स्टडी की लिमिटेशन है कि हमने स्पेसिफिसिटी फाइंड नहीं की, हमने सिर्फ सेंसिटिविटी ही फाइंड की थी ये देखने के लिए कि जो पेट सिटी है वो प्राइमरी मेलिग्नेंसी जो HCC की है उसको डायग्नोस करता है या नहीं करता। इसी वजह से जो पेशेंट ऑलरेडी प्रूफ थे हिस्टोलॉजिकली ऑन CT एंड ऑन MRI, तो उन्हीं को ही हमने इंक्लूड किया, हमने नेगेटिव पेशेंट्स को इंक्लूड नहीं किया क्योंकि हमने सेंसिटिविटी ही निकालनी थी। और ये देखने के लिए जैसे कि हमारे पास सिस्टोलॉजिकली जो थे वेरीफाइड थे पेशेंट HCC के, उसके अंदर लोअर ग्रेड भी थे, कुछ हायर ग्रेड भी थे, और उनमें जो लोअर ग्रेड थे उन्हीं में FTG PET CT ने डायग्नोस नहीं किया, एंड दैट इज द रीजन के जिनमें लोअर FTG की अपटेक वैल्यू हो तो FTG उनको PET CT उसको डायग्नोस नहीं कर सकता। थैंक यू। एनी अदर क्वेश्चन?
Thank you. Okay. So the next presenter is, sorry, the next presenter is Khalil Farouk. Khalil Farouk. Okay, we can move to the next one for the time being. Next one is Dr. Ariba Amin. So Dr. Ariba Amin, she will talk about thyroid gland incidentalomas on PET-CT, uncovering distinct patterns in various malignancies. Dr. Ariba Amin, she's from SKM. Welcome.
Assalamu
Welcome,
alaikum.
Salam.
I am Dr. Ariba Amin from Department of Nuclear Medicine, Shaukat Khanum Memorial Trust, and the topic for my today's presentation is thyroid gland incidentalomas on FDG PET-CT, uncovering distinct patterns in various malignancies. I have no disclosures. Here is the presentation layout. So thyroid gland incidentalomas are discrete lesions that are discovered incidentally on imaging modalities, which are done primarily for the evaluation of other disease process. They are frequent radiological finding occurring in up to 5% of population, and they carry the risk of being malignant. Hence, they present a potential challenge for clinicians requiring proper evaluation and thorough management. So studies have shown that the detection rate of incidentalomas by various imaging modalities like neck ultrasound is between 19 to 46%, but with very low malignancy risk ranging from 1.5 to 10%. With CT scan and MRI, it's 15%, and with FDG PET-CT is up to 4.3%. Now, this is mainly because that CT and MR are done quite frequently in our setup, and FDG PET-CT is still not the investigation of choice in many malignancies because of financial and technical constraints like availability of radiopharmaceuticals. Studies have shown that incidentalomas, which are detected on PET, they are more likely to be malignant as compared to those which are detected on other imaging modalities. So the objective of my study was to determine frequency and significance of thyroid gland incidentalomas on FDG PET-CT acquired across a spectrum of malignancies. It was a retrospective analysis of scans of 294 patients from January 2023 to August 2023 who underwent FDG PET-CT in Department of Nuclear Medicine, Shaukat Khanum, Lahore. Inclusion criteria was patients with biopsy-proven breast, gynecological, esophageal lymphoma, lung, and nasopharyngeal malignancies, both genders and age between 80 to 80 years. Patients with known thyroid disorders with primary thyroid malignancy and post-thyroidectomy were excluded from the study. These are the study parameters. We looked at the demographics, histopathology of primary malignancy, treatment history, structural findings in the gland on CT component of study like hypodensities, calcifications, necrosis, gland enlargement, and findings of PET. So findings on PET were basically, we looked at the pattern of uptake, whether it's focal or diffuse, and follow up with ultrasound, FNAC, and hormonal thyroid function tests in case of positive findings. So moving on to the results. So out of 294 patients, 36 were male, 64 were female. We took 50 patients from breast carcinoma, 45 from gynecological malignancies, 60 from esophageal lymphoma, lung, 30 male, 30 female, and 19 from nasopharyngeal carcinoma. Highest number of incidentalomas were seen in lung primary, followed by breast and gynecological malignancies. So out of 294 patients, incidentalomas were discovered in 65 patients, and we further classified them into PET-avid and PET non-avid. Among 42%, which were PET-avid, diffuse pattern of uptake was seen in 44%, and focal uptake was seen in 55%. We also correlated, we also looked at the correlation between PET and CT component of our study. So out of 65 patients, 31% were PET avid with a definite morphological correlate on CT. 11% were PET avid with no morphological correlate. Mostly patients with diffuse pattern of uptake fell into this category. And 58% were PET avid, but were PET non-avid, but they had positive findings on CT component of study. So talking about the CT component of study, changes in the gland architecture were classified into hypodensities with calcification seen in 77% of the cases, and gland enlargement of goiter in 23% of the cases. And we further subdivided them into diffuse and nodular pattern. So out of 65 patients, only 5 patients out of 65 patients with incidentalomas, only 5 patients underwent further workup with ultrasound, FNAC, and thyroid function tests. 43% had previous history of radiotherapy to the region of neck and supraclavicular fossa, and the approximate duration between radiotherapy and PET-CT was 1.5 years. So now I'm going to present few cases where PET findings were supported by further workup. This patient was diagnosed with small cell carcinoma of right lung, and on PET-CT, focal upticks were seen in both thyroid lobes. FNAC results confirm metastatic carcinoma in left lobe nodule, while a colloid nodule Bethesda category 2 in right lobe lesion. This patient was diagnosed with lymphoma. Focal uptick was seen in left thyroid lobe. FNAC results confirmed colloid nodule 2 in this lesion. This patient with lymphoma, again, we saw an uptake in the left thyroid lobe, which was focal. Ultrasound done, neck was done, and it showed TIRADES 3, and FNAC results confirmed colloid nodule Bethesda category 2. And in this patient, again, with lymphoma primary, we see FDG avid hypodensity in left thyroid lobe. It was consistent with TIRADES 1 category on ultrasound and Bethesda category 2 colloid nodule on FNAC. Serum TSH was 5.1 in this patient. So now literature review. This study was done in our institute in October 2016, and the results showed that prevalence of malignancy was significantly higher in cases of focal uptake. However, no correlation of SUV with the incidence or type of malignancy was noted. Another study was done in Canada, and the results showed that incidentalomas detected on PET are relatively infrequent, but the potential risk of malignancy remains elevated. Also, focal thyroid uptake, the detection of malignancy amongst focal thyroid uptake has sensitivity of 100% and specificity of 69%. And this study was done where they compared that in patients with focal FDG uptake, what were the results they saw on FNA. So 2/3 of patients with focal FDG uptake who underwent FNA have either malignant Bethesda 6 or benign Bethesda 2 cytology, while a minority have patients had indeterminate Bethesda 3 or 4 FNA results. So the limitations of my study was that it was a retrospective study and only limited follow-up with ultrasound, FNAC, or hormonal profile was done in patients in order to evaluate the nature of lesion. Conclusion is that metabolic activity in thyroid incidentalomas, it shows a notable trend. It's more common among women and those with a history of previous radiation exposure. And also that incidentalomas, which are detected on PET and had a focal uptake, they do require a thorough follow-up or workup with ultrasound, FNAC, and thyroid function test in order to evaluate the nature of the lesion. Thank you.
Good presentation, well done. Just out of interest, when you say that these incidentalomas are more common in women, do you think is it because breast malignancies are more common? We are talking about breast malignancy.
Yes, so when we looked at the patients with breast carcinoma, so in our study, only 14 patients had incidentalomas. Out of 50, only 14, 50 to 50 patients from breast primary, and of only 14 had incidentalomas, and hormonal status, estrogen receptors, progesterone receptors, and HER2 were positive in 7 out of 14. So yes, this can be due to the.
And were there any male patients with breast cancer included in this study?
No, male and female both were included, but there were the study duration from January 2022 to August 2023, no male patient underwent any FDG PET-CT specifically for primary breast malignancy.
Okay, thank you.
Any question from the audience?
So I have one question. So out of 5 patients who underwent FNA, you said there were 3 as a malignant and 2 of them having colloid nodule as well. So the benign clinicians can also give high FDG uptake?
Yes, sir. So the basically further follow-up within these patients were not being done. So if FDG uptake, we did not follow up for, we did not do any further follow-up with ultrasound or hormonal profile or FNA in these patients. FNA पर colloid nodule 2 आ गई थी, लेकिन उसके बाद फिर हमने इनका कोई वर्कअप नहीं हुआ, कोई फॉलोअप नहीं हुआ, तो हमें नहीं पता कि उसमें क्या ये मतलब उसमें
Colloid
लेकिन
nodule itself a diagnosis. Out
जी
of 5 patients,
जी
2 or 3 have
1 were malignant and 4 had colloid nodules on ultrasound.
and all those they give up high FTG activity.
Yes, sir. So SUV was around 7 and 8, and as I mentioned earlier, SUV is not a reliable indicator. मतलब एक कट ऑफ हम सेट नहीं कर सकते कि इस पे जो है वो benign होगा, इस पे malignant होगा.
So what's your recommendation for focal uptake nodules on FTP?
So they should all patients who had an uptake, focal uptake on FDG PET-CT, they should underwent a proper follow up with ultrasound, FNAC and thyroid hormone profile. और इनके अगर हमारे पास ultrasound पे colloid nodule आ जाती है तो maybe हम उसको follow up कर सकते हैं within 1 to 2 months. Further दोबारा workup repeat करवा सकते हैं.
Colloid nodules, they don't need any follow-up.
जी sir.
My understanding is. Thank you.
Thank you very much. Dr. Arij, so the next presenter is Dr. Arij Ejaz from SKM, and she will talk about added value of forearm bone mineral density assessment on routine DEXA scan.
Assalamu alaikum. I'm Dr. Arij, resident in Nuclear Medicine Department. Today, the topic of my talk is the added value of distal forearm BMD evaluation in the routine DEXA scanning. I have no financial disclosure or conflict of interest to declare. This is a brief layout of my presentation. So the DEXA is the gold standard non-invasive imaging modality for measuring the bone mineral density. It detects the bone loss by measuring the attenuation of low radiation X-ray beam through the bone. Current standard protocols involves the BMD acquisition at 3 sites, that is the lumbar spine, femoral neck, and hip, which is called as the central DEXA. While the peripheral DEXA involves a BMD measurement at the forearm. Currently, International Society for Clinical Densitometry official positions recommend forearm BMD evaluation in certain cases, such as those with the known hyperparathyroidism, obesity, and in patients when the surrendered sites of BMD cannot be reliably interpreted or measured. However, recently the treating physicians have shown increasing interest in the evaluation of forearm BMD in addition to the standard sites, which has led to the objective of my study to evaluate the added value of forearm BMD in routine DEXA scanning. We retrospectively studied 454 data of 454 patients who underwent distal forearm assessment in the DEXA scan from January 2018 to July 2024. All the adult oncological and non-oncological population, irrespective of the gender, was enrolled in the study. Now, all the pediatric population, those with the non-osseous metastasis, and patient on the anti-resorptive therapy for more than 1 month were excluded from the study criteria. This slide shows the standardized fracture risk assessment tool that we do to calculate the 10 years probability of osteoporotic fracture in the study population. Moving to the next slide, these tables show the WHO diagnostic criteria, which we use to report the DEXA scan using the T and C scores of the sites. In postmenopausal women and men above the 50 years, and premenopausal women and men below 50 years. Now let's look into the results. So the mean age of study population was 62 years, ranging from 21 to 91 years. And there was predominance of females with 90% being postmenopausal. Next, we compared the concordance and discordance between the two imaging modalities, that is the central and distal forearm. Out of 454 patients, 59% had concordant results showing similar BMD results at both the sites, while 41% had discordant results. When we further looked into the discordant group, there were worsening of BMD in 62% of the discordant, which is almost 25% of the total population. We further looked into the clinical indications for the acquisition of distal forearm in the study population. In this, we found that rheumatoid arthritis was the most common clinical indication in our study group, followed by hyperparathyroidism, fracture history, age-related scans, and malignancies. Then we looked into the risk factors that led to the worsening of BMD on the distal forearm assessment, and we found that smoking had a significant effect of deteriorating the bone mineral density at distal forearm, followed by parental fractures, rheumatoid arthritis, and glucocorticoids. In this slide, we have compared, general comparison was done between the central versus distal forearm BMD values in postmenopausal women and men above the 50 years and premenopausal women and men below the 50 years of age. So in central DEXA, there were 10% of the patient who had normal BMD, but they were diagnosed to be osteoporotic on the distal forearm. 8% had normal BMD and it was diagnosed to be osteopenia on the forearm assessment, while substantial of 73% had osteopenia and they were upstage to osteoporosis based on the distal forearm BMD results. Then in premenopausal and men below the 50 years, within range BMD was found on the central DEXA, but it was upstage to within range, upstage to below range on the distal forearm assessment. Coming towards the cases of that we included, this is a 76 years old postmenopausal woman and with multiple risk factors. She underwent central DEXA with forearm assessment, and the central DEXA revealed normal BMD values, while the forearm DEXA revealed severe osteoporosis. So she was labeled severe osteoporotic on the basis of forearm BMD assessment. The next case is a 75 years old male without any risk factor. He had normal BMD at the central DEXA, while osteopenia was diagnosed on forearm assessment. If we look into the literature, which are evaluating the importance of inclusion of distal forearm into the central DEXA, this study by Zaman et al. Suggested that the BMD at the distal forearm is significantly lower as compared to the hip and spine regions. So it is earlier detector of risk of osteoporosis as compared to the other sites. There is another study done by Worley in the Journal of Nuclear Medicine, who concluded that 1/3 of the patients show diagnostic discordance due to the forearm bone mineral density evaluation. Another study also emphasizes the addition of forearm BMD evaluation as it leads to the increased diagnostic sensitivity of osteoporosis. There were few limitations to my study. It was a retrospective study. No follow-up was available to assess if the BMD were deteriorated on the other side on the follow-up scans. And another limitation was that we studied a variable group of clinical indications. To conclude from the study, incorporating the distal forearm DEXA scan leads to the worsening of BMD in 1 in 4 of our patients. It improves the osteoporosis detection and enhances the ability to address the interventions earlier in the treatment course. And the most common risk factor for the deterioration of BMD at the distal forearm were smoking, parental fractures, and rheumatoid arthritis. Thank you. Any questions?
Thank you very much. Very nice study. My question is, did you consider that which forearm you use in obtaining this data, whether the person is right-handed or the left-handed?
So non-dominant is forearm is used for the assessment process. Yes.
Okay,
Yes,
that's
sir.
important. Yeah.
Yes, sir.
Thank you.
Okay, and how much time it adds? If
Sorry,
we
it
add
was,
the,
sorry.
how much time it will add if we add the forearm assessment as well in the whole DEXA scan?
Uh, five, five, 5 years?
Almost
5 minutes.
5 minutes, okay.
Mm.
So will it affect how many patients you can do in one day? You know, in terms of looking at how many patients you are doing?
Sir,
You know, looking at, sorry, I'm saying it for the reason that if we talk about our MR scanners, if you're going to add any additional sequence, then we have to see the impact.
On the number of scans acquired per day. Sir, DEXA is not that much busy as compared to the other modalities. Like patient number is significantly lower as compared to CT and MRI. So this can be included in the protocol in respect to the time duration.
Thank you.
I have one question.
Yes, sir.
इसमें जो आपका inclusion criteria था, उसमें
Yes.
वो patients थे who had a request from the clinicians to add the forearm.
Yes, sir. Yes, sir.
ऐसे था उसका?
ये ऐसे ही था सर,
तो
उनकी बेसिस पे.
क्या recommendation है? Now you will start adding forearm for every patient?
सर एक्चुअली देयर मेजोरिटी तो हमारे पास क्लिनिकल इंडिकेशन हाइपरपैराथायरॉइडिज्म होती है, लेकिन हमने ये भी देखा कि रिमेटॉइड आर्थराइटिस में भी बहुत ज़्यादा इसकी इंडिकेशन थी, और सेकेंडरी ऑस्टियोपोरोसिस के केसेस में भी है, या लंबर स्पाइन जब फिक्सेशन हुई हो तो तब भी हमारे पास की जाती है. सो या कुछ WHO की है, लेकिन समटाइम्स दे वांट देमसेल्फ कि भी हम ये साइट करवाना चाहते हैं एक्वायर, वो रिक्वेस्ट पे होता है कि इनका फोर आर्म असेसमेंट करनी है तो फिर किया जाता है, लेकिन WHO की रिकमेंडेशंस में से नहीं आई है.
Thank you.
Right, and so this was by Dr. Riba Amin. So now we can move to the next one. Sorry. Arish Ji. Okay, so the next one is Dr. Sana Munir. Sana, yeah, thank you. So Dr. Sana Munir Gill, she is from SKM and she's going to present on reflecting on over a decade of FDG PET in RCC, renal cell carcinoma. Is this the time for more harmonized utilization? So welcome.
Assalamu alaikum. I'm Dr. Sana Munir Gill from the Department of Nuclear Medicine. I feel honored to present my study entitled Reflecting on Over a Decade of F18 FDG PET-CT in Renal Cell Carcinoma. Is it time for a more harmonized utilization? I have no disclosures. This is the general layout of my presentation. So renal cell carcinoma is the most common urological malignancy and is the 14th most common tumor overall, with the 16th highest mortality rate amongst all tumors. If you look at the management guidelines for renal cell carcinoma, recent ESMO guidelines from 2024 incorporate CT scan for the diagnostic workup with no mention of FDG PET-CT. NCCN guidelines quote that the value of PET in RCC remains to be determined. Interestingly, European Association of Urology does not recommend FDG PET-CT in either staging or even in the follow-up of renal cell carcinoma patients. On the contrary, the Royal College of Radiologists provide evidence-based indications for the use of PET-CT in not only staging, but also restaging of renal cell carcinoma. And it also says that it has a role to play in patients in which there is clinical suspicion of disease recurrence and in monitoring treatment response. That brings me to the objective of my study, which was to explore the effectiveness of FDG PET-CT in staging and restaging of renal cell carcinoma. After obtaining approval from the Institutional Review Board, we retrospectively analyzed 203 FDG PET scans from 134 patients over a span of more than a decade, from 2011 to August 2024. These are the few parameters that we studied in our study. This image gives you the physiological distribution of FDG after standard patient preparation and standardized imaging protocol. Now let's discuss the results of my study. Mean age of my patients was 55 years and 68% of the patients were males. Most common indication for PET scanning was restaging, followed by staging and response evaluation scans. Clear cell carcinoma was the most common histopathological variant, followed by RCC of unclassified type, followed by papillary carcinomas. This table gives you a breakup of lesions that we saw on PET-CT region-wise, and as we can see that most commonly the nodes were seen. However, all these regions showed increased metabolic activity in case of any positive lesions, with splenic metastatic deposits showing the highest uptake value with the mean SUV of 10.1. 84 PET scans had correlative CT scans, of which we found that 29% of the cases, they were concordant lesions. In 71%, we found discordance. Of this discordant group, in 87% of the cases, PET-CT was able to have additional lesions, and in 13%, PET-CT was able to downstage the disease. We were intrigued by the lack of interest shown by our European colleagues in the use of PET-CT. So we analyzed 49 staging scans in our data set, and 40% of these had avid lesions in the renal bed, with a significant mean SUV of 5.6, which was above reference hepatic SUV. When we look at the impact PET made on the patient management, of the 103 patients of whom we had follow-up data available, in 15% PET prompted escalation of treatment. In 25%, there was initiation of tyrosine kinase inhibitors. In 19%, it led to surgical excision, and in 5% radiotherapy. The remaining continued with a prior management plan. 30 patients in our data set had serial PET scans, and in 80%, there was change in management. Now let's look at a few interesting cases. This is a staging PET-CT of a 47-year-old with a lesion in the left kidney with an SUV of 2.7. PET-CT ruled out distant metastatic disease, and patient was then treated with localized treatment only. This 48-year-old gentleman had serial PET scans at our center. In 2020, he had avid mediastinal lesions. By 2021, as you can see, there was increase in size and avidity of these lesions. At this point, he was started on TKIs. The follow-up imaging in 2023 showed disease progression by virtue of interval development of new osseous lesions, as shown here. And even in 2024, there were further metabolically active osseous lesions. This is a restaging scan of a 71-year-old who had clinical suspicion of disease recurrence. As we can all see that there is FDG avid soft tissue density lesion in the right nephrectomy bed, consistent with the clinical suspicion of disease recurrence. In the recent past, there has been increased interest in the role of FDG in renal cell carcinoma. So we'll just have a quick review of a few studies. This meta-analysis suggested that FDG PET-CT can serve as a prominent surveillance technique with robust diagnostic performance in detecting recurrences. Our Indian colleagues in their study found PET-CT to be an efficacious modality imaging modality for primary and metastatic renal carcinoma, especially due to its ability to pick up areas of increased metabolic activity early on in the course of the disease. In this study, the SUV, which is a marker of increased metabolic activity in the lesion, they suggested that SUV derived from the staging PET-CT was a predictor of progression-free survival, and it is very effective for detecting disease recurrence as well. This research letter by Fernandez et al. Importantly suggested that most patients with RCC were FDG PET positive, and it can potentially serve as a novel marker for prognosis, response, and treatment guidance. So with the changing paradigms in the world of molecular imaging, new traces are being investigated for their potential role in the management of renal cell carcinoma. To mention a few, there is F18-FAPI, and gallium-68 PSMA. And more recently, zirconium-labeled immunoglobulins have also been investigated. However, these still have to go multiple trials before they become FDA approved for the RCC. But still, FDG PET-CT still plays a role and has demonstrated to be a superior predictor of outcomes in metastatic renal carcinoma. These are a few limitations of my study. In light of all the discussion, I would like to conclude that our institutional experience adds to the building evidence in favor of more harmonized use of F18 FDG PET-CT in staging, restaging, and treatment management of patients with renal cell carcinoma. Thank you very much.
No questions, but yeah, very nice study, very nice.
Thank you, sir.
Thank you very much. Just a small quick. Jirihan? So, my question is, so why PET is not included in the guideline?
So that is our question as well. We are also suggesting the same by our study, and more work is being done world over to suggest that it should be included in the management guidelines. But for now, possibly because FDG is normally excreted from the kidneys. But if you go back, if I can show you the physiological distribution of FDG, this uptake is not seen in the cortex. It's rather more in the collecting system. So yes, it should be included, and that's what we would like to suggest.
Thank you.
Histopathology remains the gold standard. I think histopathology would remain the gold standard by all means, as in case of all other tumors. As I mentioned before, that probably normal excretion, but yet again, RCC is from the cortex, not from the collecting system. Yeah, and then we also have dual time point imaging, in which we can have an additional lesion after hydrating the patient more and urinary excretion is more. After that, we again check, repeat a limited scan. And if the metabolic activity is going up, then that is more convincing for the primary malignancy. Thank you.
Thank you very much. All right, so this was, yeah, so now so thanks for presenting. And now the next one is Dr. Maham Zafar. Maham Zafar from AKU, Aga Khan. Online to nahi hai inki presentation. Maham Zafar. Nahi hai. Okay, so we can move to the next one in the meantime. Okay, so next one from SKM, Dr. Sumaya Abdul Rahman. Sumaya Abdul Rahman. Okay, we can move to the very last one. Dr. Mariam Malik. Yes, she is here. So Dr. Mariam Malik, she is from SKM Radiology, and she will talk on imaging review of rare sinonasal tumors presenting in our institute. Thank you, Dr. Mariam.
Thank you, sir. Assalamualaikum. I'm Dr. Mariam Malik from the Department of Radiology, Shaukat Khanum Hospital, Lahore, and I'm a fellow in body imaging. So I'll be talking about the imaging review of rare sinonasal tumors presenting in our department. So the objective was to make the radiologists aware of the imaging features of different histopathological subtypes of sinonasal malignancies, and to decrease the false interpretation of the signs of malignant tumors as rhinosinusitis due to the complexity of imaging features of sinonasal region, and also to reduce the patient mortality by early detection of malignancies, leading to the early treatment of the patients. So first is 29-year-old female patient presented with nasal blockade, epistaxis, and blurring of vision. And here we can appreciate there is a calcified mass involving the right nasal cavity. And there's also involvement of the clivus. And there is septal deviation towards left side. And here we can appreciate it is also involving the sphenoid sinus in the posterior ethmoidal air cells. And there's extension into bilateral middle cranial fossas. And also there is intracranial extension with erosion of the cribriform plate, and there is bilateral intraorbital extension with erosion of lamina papyracea, and also there is involvement of the greater wing of sphenoid. On MRI, we can appreciate that there is signal void areas seen in the region of the tumor, and it is showing heterogeneous contrast enhancement. So this is suggestive of a calcified nature of this mass lesion. And also it is locally aggressive with bilateral intraorbital extension as well. And on follow-up, This patient showed subdural collections and multiple infarcts were seen. And 11 years after diagnosis, the patient expired. So this patient had a high mortality. And on histopathology, there was osteoid-producing tumor. And as it was aggressive on imaging, so most likely diagnosis was nasal osteosarcoma. And it is a rare tumor, representing less than 10% of all osteosarcomas. Next is 38 years old male, presented with epistaxis, nasal obstruction, polypoidal nasal mass, bleed to touch. And here we can appreciate a soft tissue density mass lesion with no calcifications, as was seen on the previous scan. And it is causing bilateral erosion of lamina papyracea with intraorbital extensions. And here we can appreciate there is extension into the intracranial extension with erosion of cribriform plate. And there's also intraorbital extension bilaterally by erosion of the lamina papyracea. And here we can appreciate on MRI, there is a sinusitis. We see it is appearing very hyperintense on T2 as compared to this mass lesion, which is appearing heterogeneous signal on T2. And there is also bilateral intraorbital extension with mass effect on bilateral medial recti muscles. And there's also, on contrast enhanced T1, we can appreciate multiple flow voids are seen, suggestive of the vascular nature of the lesion. And there's also intracranial extension and also intraorbital extension bilaterally with lots of fat film between the medial recti muscles. And on FLAIR, we can appreciate there is visogenic edema in the bilateral frontal lobe, suggestive of the involvement of the frontal lobes with intraaxial lesions. And this patient had distant metastasis, lung and lymphadenopathy. And on follow-up, this showed disease progression with preseptal tissue involvement. So this was aggressive in nature. So patient expired 1 year after the diagnosis. And the histopath diagnosis was sinonasal yolk sac tumor. And it had incidence of just 1%. Next is 43 years old male patient with nasal blockade and loss of vision on both eyes. So here again, we appreciate an aggressive mass lesion appearing hypointense on T1 with bilateral intraorbital extension. And there is also extension in the right temporal region with mass effect on the temporal lobe. And on T2, it's a predominantly low signal intensity mass lesion with heterogeneous appearance. And there is again bilateral intraorbital extension. And on sagittal image, we can appreciate there is erosion of the clivus and the cellular region is also involved, suggestive of the aggressive nature of the lesion. And on contrast enhanced imaging, again, we can appreciate there is bilateral intraorbital extension with involvement of the bilateral medial recti muscles and also inferior medial rectus on the left side. And also it is extending into the maxillary sinus. And again, on follow-up, it had a progressive course and it was diagnosed to be Ewing's sarcoma. And again, it's a rare tumor presenting only 1 to 2% of the cases in head and neck region. Next is 65 years old male patient with nasal blockade and right ear pain. And on T1, we can see there's a hypointense posterior ethmoidal mass lesion, also involving the sphenoid sinus as well. There is no intraorbital extension seen. And on T2, we can appreciate there's a sinonasal mass with erosion of the involvement of the clivus. There is no intracranial extension seen in this case. And it is an intensely enhancing mass lesion with a partial encasement of bilateral carotids. And here there is extension into the bilateral infratemporal fossa with mass effect on the temporal lobes. And on follow-up, this had an aggressive course and it had mets in the temporal region. And however, there was no mortality. So on histopath, it was a well-differentiated neuroendocrine tumor, grade 1. And also it accounts only for 5% of the cases of sinonasal malignancies. 43 years old male presented with epistaxis and nasal obstruction from 1 month. And here we can appreciate a soft tissue density mass with heterogeneous enhancement involving the right nasal cavity and also extending into the right maxillary sinus, causing its obstruction and resulting in maxillary sinusitis. And here again on coronal image, we can appreciate there are heterogeneous enhancing mass lesion with causing obstruction of the maxillary sinus on right side, resulting in sinusitis. However, there is no intracranial or intraorbital extension. And here on bone window, bilateral lamina papyracea, they are intact. And on PET, it had uptake suggestive of malignant nature of the lesion. And on follow-up, after 7 months, it showed treatment response with decrease in size of the right nasal mass. So patient is still on follow-up, and on biopsy, it was sinonasal pteudocarcinoma. And this is also rare, contributing only 3% of the malignancies of head and neck region. And last is a 59 years old female patient presented with nasal obstruction and epistaxis for 1 year. And we can appreciate on axial CT, there is an aggressive looking lesion causing erosion of the lamina papyracea bilaterally with intra-orbital extension more on the right side with involvement of the medial rectus muscle as well. And on bone window, again, we can appreciate there is erosion of the lamina papyracea bilaterally with intra-orbital extension. And this is also causing obstruction of the maxillary osteometrial complex on the right side with maxillary sinusitis as well. And here again, we can appreciate enhancing mass lesion with erosion of the with extension into the right maxillary sinus. So this also had a progressive course on follow-up imaging, and this was a high-grade sinonasal undifferentiated carcinoma. And this is also rare, contributing to only 5.8% of the sinonasal tumors. Now this is just to summarize. The intracranial axial lesion was seen just in yolk sac tumors and neuroendocrine tumors. And calcifications were seen only in osteosarcomas, which was not seen in other cases. And the enhancement pattern was intense enhancement with pterodocarcinoma showing mild heterogeneous enhancement. And there was no bony erosion in pterodocarcinoma, but the others showed bony erosions. And osteosarcoma showed T2 signal void areas. And all had progressive course except for pterodocarcinoma, which had a good treatment response. And osteosarcoma and yolk sac tumors, they had high mortality, leading to the death of the patients. So we conclude that all sinonasal tumors with specific histopathology can be differentiated based on their location, enhancement pattern, bony involvement, and signal characters on MRI and course of the disease process. And imaging is crucial for detection, differentiation, staging, surgical planning, and follow-up and surveillance of sinonasal masses. Thank you.
Thank you very much. Nice study. Very good. Could you tell me that how many of your patients had fungal disease as well, which is obviously one of the predisposition of malignancy?
We actually studied all the rare sinonasal malignancies, not for the infections. We had a study on just the rare features of the sinonasal tumors.
But did they have any simultaneous fungal disease?
No, sinusitis was there, but not fungal.
Okay.
Yes.
Okay. Thank you.
Thank you very much, Dr. Mariam. A good presentation. Just wondering, so in terms of take-home message, if I'll talk about what message I'm going to take from this one. Will this change our management in terms of, like the need for biopsy or any further diagnostic tool?
Biopsy is the gold standard for obviously diagnosing these tumors, but imaging can help us in early detection of the diagnosis of the lesion. In case that biopsy is difficult to obtain or the patient is critical, like we can assess from the imaging features that what could be the histopathology of the patient, and early management, early treatment can be started in these cases. As some of the cases we saw, they had a very rapidly aggressive course.
Yeah.
So early treatment can be started in those cases.
Thank you.
Thank you.
Thank you. Any latecomer or who didn't present who is here now? So it looks like, we have got plenty of time for tea break today. I'll finish. So any question, anything from any of those presenters or anyone before we conclude it?
Thank you.
Thank you very much. Cheers. Bye.